And ladies and gentlemen, I'm going to talk about conventional management of Rhesus blood group. Before we go into what we believe is the next step, the next evolution, and how to be precise. I'm the past MOMS president, not the current president, and I'm also the president-elect of OGSM. Ladies and gentlemen, I've got no conflict of interest for this talk, and this talk is going to be about 25 minutes long. Now, what are the highlights of my talk? I'm going to talk about what is current, what is conventional, what has been the way for the last, I would say, since the 1960s. We manage fetal Rhesus blood group with one assumption. Now, never in medicine, we often assume, but assumption in Rhesus negative is that the baby is blood group positive. But moving forward, ladies and gentlemen, I think the modern management is based on precision, on confirmation of the fetal blood group, whether negative or positive, not with the assumption that every mother who's got Rhesus negative will have a Rhesus positive baby. So what has been recent with regards to Rhesus negative blood group? I think we now know that we now live in the era of non-invasive fetal genotyping of fetal blood group. The next speaker, Ms. Sarah, is going to talk about non-invasive modalities in testing. What is current, ladies and gentlemen? Universal screening of antibodies, not once, but twice at booking and at 28 weeks for all mothers. Now, what is good? We do check for blood group, but we rarely check for antibodies. Now, this must be done. This must be repeated at 28 weeks again. Although we're going to talk about non-invasive testing, there is another option of an invasive testing. Now, this is not routinely done, but if you are to do an amniocentesis for another condition, you can add on an additional test of confirming the baby's blood group via an invasive testing. Now, ladies and gentlemen, another part where we should evolve in Malaysia, I believe, is the importance of doing a Clay-Hoyer's test and guiding NTD management based on the Clay-Hoyer's test for any pregnancy beyond 20 weeks and even after childbirth. A little bit about Clay-Hoyer's test. If you give someone 500 international units of NTD, that covers 4 mils of fetal maternal hemorrhage. Every additional mil thereafter, you have to give an additional of 125 international units of NTD, a point of which I will highlight further in my talk. We have moved from a 2-dose prophylaxis regime to a single-dose prophylaxis, and that is new. For those who have got allo-immunized, we are talking about monitoring based on titers. Everyone knows that we don't really have to do an invasive testing to confirm fetal anemia, but this can be done via monitoring of MCA Doppler for mothers who have got titers. How flow cytometry is far superior than the Clay-Hoyer's test. And finally, at birth, a simple test to do is a cord blood DAT, hemoglobin and bilirubin level at birth. And these are some recent changes with regards to Rhesus negative blood group identification. Now, how common is red cell antibodies, ladies and gentlemen? It is not common. The incidence has been quoted to be between 0.4 to 1.2%. Now, how common are Rhesus blood group in Malaysia? It's about 1% incidence. But having said that, if a mother has got an antibody, the mother's Rhesus negative, there's an increased incidence of hemolytic disease of the fetus and newborn. And our entire aim is to prevent a possibility of hemolytic disease of the fetus and newborn. Although it is rare, this can be prevented. Now, what are the significant antibodies, ladies and gentlemen? The entire talk today is going to be about anti-D, but you can talk about 2 types of blood groups. Those that are high risk towards hemolytic disease, which are anti-D, anti-C, and anti-K. Then you can talk about moderate risk, where the incidence of fetal hemolytic disease is significant, is anti-E, anti-FY, anti-JK, anti-C, and anti-CE. For perhaps possibility in the next few years, we could actually do a non-invasive testing to confirm. But ladies and gentlemen, it is not often always rhesus. It's good to think about high risk and moderate risk of antibodies in the mother. So what history to ask? I think it's important to know whether this pregnancy was conceived spontaneously or whether it was a donor egg. Often in Malaysia, we are too polite. We don't often ask who the partner is. It's good to ascertain the partner's blood group and whether the partner is the father of this child and current child. History of asking the mother, what is her blood group? She may remember. Whether she had any prior blood transfusion, that is important. Whether she had an organ transplant. Further obstetric history, ask about stillbirth, ask about previous history of fetal hydrops, past history of intrauterine transfusion, and when did this happen is extremely important, because if it was to happen, it usually happens again around the same gestation. But ladies and gentlemen, fetal anemia usually only manifests later in the pregnancy at around 26, 27, 28, 29 weeks. Rarely does it manifest earlier on. Further history, unexplained severe neonatal jaundice, neonatal anemia requiring transfusion are red flags that one should trigger towards checking the mother's antibody. But the current understanding is universal screening of blood group and antibody at booking and at 28 weeks. Now, please don't really wait until the baby develops hydrops fetalis, because the moment the baby develops hydrops fetalis, the outcomes are usually poor. Not always lethal, but the outcomes is poor. And our main aim and objective today is to develop, is to prevent, is to diagnose, is to screen early to prevent before the baby develops hydrops fetalis. So what is the antenatal management of a mother with NTD? Confirm the blood group. Ensure there are no antibodies, which means she's got no prior immunization at booking at 28 weeks. Confirm the paternal blood group. And then you've got two ways to confirm the fetus. The current way, we assume that the fetus is positive. But sometimes you have two options, a non-invasive measure of confirming the fetal blood group or an invasive measure. And then if you have ascertained that it's got no prior alloimmunization, the current recommendation is a single regime prophylaxis of anti-D 1,500 units between 28 to 30 weeks. The old guidelines used to recommend a double regime, a lower dose of 500 international units at 28 and 34 weeks. So if you've got two options, ladies and gentlemen, a single regime or a double regime, depending on the dose. And finally, if you do have a mother who has got a history of alloimmunization, where she does have antibodies at booking, refer her to a fetal medicine specialist. There's no benefit of anti-D prophylaxis. You need to monitor the titer. You need MCA Doppler surveillance based on the titer. You need to screen for fetal anemia with a guided antenatal precise management. Now, what are some sensitizing events that can potentially increase fetal maternal hemorrhage? I think our current practice, we seldom or routinely do a Clay-Hoyer's test. I think we should routinely do it. I want to think of a desensitizing event. Anyone who has got an amniocentesis or a chorionic villus biopsy who's got antibodies. This can safely be done, but the mother has to be given anti-D prophylaxis if she's got no prior immunization. Any mother who's got antepartum hemorrhage, performing an ECV in a rhesus negative mother, any mother with abdominal trauma, any mother with stillbirth or intrauterine death, any mother who's having an intrauterine surgery or a fetal therapy, a normal delivery which is traumatic, example, an instrumental delivery, or the use of intraoperative cell salvage, or the incidence of PPH or sepsis, all of which increases possibility of desensitizing events where the fetal-metal hemorrhage can be significant. So apart from history, apart from routine surveillance, think of potential sensitizing events during pregnancy. What is the management, ladies and gentlemen? The old guideline says below 10 weeks or below 12 weeks, NTD is not recommended, but that is not always true for everyone. Less than 12 weeks, certain cohort of patients do need NTD prophylaxis. The dose is 250 international units. And who are the 4 cohorts of patients below 12 weeks? Patients who have got significant vaginal bleeding with severe pain. Patients who undergoes a surgical management of the miscarriage. Patient who undergoes a surgical or a medical termination with significant pain and bleeding, or a patient with ectopic pregnancy who's 9 weeks pregnant, you did a self-injectomy and turned out that she's Rhesus negative, or a management of a molar pregnancy. Now, this cohort of patients, although they are below 12 weeks, if she had significant pain, if she had significant bleeding, although she's less than 12 weeks, the recommendation is to give her 250 international units of ROGAM, provided she has got no prior history of alloimmunization. Between 12 to 20 weeks, the evidence is clear. Any patient who's got a significant event during pregnancy, the recommendation is to give 250 international units, especially if she's got a potentially sensitizing event, namely antepartum hemorrhage, threatened miscarriage, complete miscarriage, CVS or amniocentesis. Yes, she does need. Now, after 20 weeks, the dose doubles, and the current dose, which is used by everyone, is 500 international units. Now, what is different after 20 weeks? The dose is 500, but now the recommendation is to universally quantify fetal-metal hemorrhage by using a Clay-Hoyer's test to diagnose a small subset of population who might need higher doses, because 500 only covers up to 4 mils of fetal-maternal hemorrhage. And that is the current recommendations. Now, what if the mother had an antepartum hemorrhage? She bled. You gave her ROGAM of 500 international units. After that, she continues to bleed and bleed and bleed throughout the pregnancy. So the recommendation is to do a 2-weekly Clay-Hoyer's test, looking at fetal-maternal hemorrhage, and an irrespective of the test is to repeat 500 international units of ROGAM every 6 weekly until the bleeding stops. And that is the guidelines from the British Society of Hematology. We spoke about NTD thromboprophylaxis. The old regime is to give 2 doses of 500 international units at 28 weeks and repeat it again at 34 weeks. Now, why 28 weeks? This is a time when the lower segment forms, and this is a time when the mother has got a significant possibility of having a fetal-maternal hemorrhage. Now, 500 international units of ROGAM stays in the system for up to 10 to 12 weeks. That is why it's recommended to repeat it again at 34 weeks. But because of the preparation of ROGAM, which is available in Malaysia, which is at a higher dose, you can also adopt a single dose regime, which is 1,500 international units. Give it once between 28 to 30 weeks antenatally. Now, perhaps the patient would have had a prior event, would have had a bleed, would have had 500 international units of ROGAM because she had an antepartum hemorrhage. You have to still give her 1,500 units at 28 to 30 weeks once again, although she would have had 1 or 2 or 3 doses prior to this. Now, what are the available options of NTD? In the UK, there are 2 options. One is the DGAM, which comes in 250 for below 12 weeks, 500 for after 20 weeks, 1,500 and 2,500. And this is only available in IM. In Malaysia, we have got the Prophylax, which comes in a pre-filled syringe and comes in 1,500 international units. Now, interestingly, the Prophylax is available in IM or IV. You may use both options, but the commonly used option is IM. So in Malaysia, ladies and gentlemen, we have the Prophylax, which is a higher dose, but not all patients need such high doses. At delivery, or in the event of a stillbirth, the recommendation is to give 500 international units, depending on the baby's blood group, especially if the baby's blood group positive. Or if the baby had a stillbirth, you're unable to determine the blood group of the baby, the recommendation is to give 500 international units. But you must repeat a Clay-Hoyer's test, even if it's a stillbirth after 20 weeks, or even it is a normal vaginal birth at term, because you have to exclude a possibility of a fetal maternal hemorrhage beyond 4 mils. So ladies and gentlemen, everyone needs a Clay-Hoyer's test after 20 weeks of pregnancy. If the Clay-Hoyer's test is positive, then you have to give additional NTD, the dose of which I will discuss after this. So to summarize the 3 different tables, ladies and gentlemen, for mothers who have got no prior allo immunization, confirm at booking that they've got no antibodies. Do an indirect Coombs test, which should be negative. Confirm the father of the baby's blood group. No benefits of NTD below 12 weeks with some exceptions. And the exceptions are patients with ectopic, molar, termination, repeated heavy bleeding with abdominal pain. These patients, although less than 12 weeks, they need NTD prophylaxis. Between 12 weeks, the evidence is clear. Every patient who's got Rhesus negative, if you can't confirm the baby's blood group, need NTD, and it could be either a medical or a surgical termination, a threatened or a spontaneous miscarriage, a molar, ectopic, or a CVS. If you have multiple pregnancies, it gets a little bit tricky. The Royal College of Australian and Canadian guidelines recommends a higher dose because of the bigger placenta. They recommend a dose of 500 instead of 250. Below 12 weeks, there's no benefits of doing a Clay-Hoyer's test. But after 12 weeks and beyond, everyone should have a Clay-Hoyer's test. And the dose is now doubled from 250 to 500. If the bleeding persists, do a 2-weekly Clay-Hoyer's test. Give additional NTD if the Clay-Hoyer's test is positive, depending on the level of fetal maternal hemorrhage. But irrespective of the results, the mother continues to bleed and bleed and bleed, give her 6-weekly international units of 500 IU of program. All asymptomatic patients at 28 to 30 weeks, a single dose of 1,500 is the current recommendation, or you can use the old guidelines of 2 doses of 500 at 28 to 30 weeks. And postnatally, confirm the fetal blood group, do a Clay-Hoyer's test. The dose is 500 international units, but further dose depending on the Clay-Hoyer's test results. What are some additional unique circumstances? If the mother had a previous desensitizing event, although she would have had IM ROGAM of 500 units, say at 16 weeks, at 20 weeks, at 24 weeks, you still have to repeat a single dose regime of 1,500 at 28 to 34 weeks. The mother had a stillbirth, you're not able to quantify the blood group of the baby. The recommendation is yes, still give the mother ROGAM, but still do a Clay-Hoyer's test. In Malaysia, we don't use intraoperative self-salvage. It is safe, it is not contraindicated, but the recommendation is to give 1,500 units, not 500 units, but check a Clay-Hoyer's test. And NTD should ideally be given within 72 hours. But for some unknown reason, we have missed that window of opportunity. There's still benefit to be given within 10 days of delivery, but best within 72 hours. I believe, ladies and gentlemen, as we speak about precision in NTD management, the management should be guided by a Clay-Hoyer's test. Now, what is a Clay-Hoyer's test? It is recommended to be done after 20 weeks of gestation. It is to identify all potential sensitizing events. It should be done universally after 20 weeks, universally after birth. Now, why? If you use a lower regime, 500 only covers 4 meals. In Malaysia, we use 1,500, which covers 12 meals. But some patients may have a fetal metal hemorrhage of beyond 12 meals. Now, for every additional meal of fetal metal hemorrhage, you need to give an additional of 125 international units of program. Let me give you an example. The mother had a normal delivery. You gave her 500 international units of NTD. You did a Clay-Hoyer's test. The Clay-Hoyer's test says that there is 2 meals of fetal metal hemorrhage. So now you have to give her 300 extra international units of NTD and repeat the Clay-Hoyer's test once again until there's no cells detected in fetal metal hemorrhage. Now, although you can have the IM and the IV route, the IM is preferred. The IV in Malaysia, should you give an IV, remains controversial. Some people believe that patients with high BMI, the test to check the titers may be inaccurate, and similarly, the quantification of fetal metal hemorrhage may be lower, but that remains controversial. To prevent anaphylactic reactions, the doses of NTD given to the mother should ideally be from the same batch. And if a mother needs a significant amount of high doses, instead of giving one stat dose, you can give divided doses. Example, last week we had a mother who required almost 2,500 international units of program. Instead of giving her 2,500 straight away, you can divide that into divided doses, provided it is given within 72 hours. For better absorption, deltoid is preferred than the gluteal. And after giving her NTD, check again 72 hours later to ensure you have obtained complete clearance. Or is to do a far more superior test than a Clay-Hoyer's test, which is known as flow cytometry, which is far more sensitive in detecting fetal metal hemorrhage. And this is available in Pusat Darah Negara and in some tertiary hospitals in Malaysia. Flow cytometry is the way forward. Now, what if the mother have already been alloimmunized? Then, ladies and gentlemen, there's no benefits of NTD. It is now time to refer her to an expert, a fetal maternal specialist unit. It's good to check the titers for weekly up to 28 weeks. And after 28 weeks is 2 weekly until delivery, because as the pregnancy advances, the incidence of fetal metal hemorrhage and antibodies may change. If the titers are below 4, you can be reassured that the risk of fetal hemolytic anemia is low. But if the titers are above 4, then the risk is mild to moderate. And this patient now needs an MCA Doppler surveillance weekly to screen for fetal anemia. And if there is evidence of fetal anemia, it needs to be treated. But if the levels are above 15, the risk of severe hemolytic disease of the newborn and the fetus is high. So it's good to guide your practice based on the antibody titers. Now, what are the early signs of ultrasound that you may be able to detect in the primary care? Polyhydramnios, skin edema, and cardiomegaly may be early signs. But ladies and gentlemen, ultrasound signs are often late signs. It's best to go based on the titers, based on MCA Doppler, which is far more sensitive. But these are some early signs that you may detect prior to development of hydrops fetalis. But what will a fetal medicine specialist do? They monitor the MCA Doppler. And based on monitoring of the MCA Doppler, if it's above 1.5 median, then confirms that the baby has got fetal anemia. It also depends on the gestation. But basically, ladies and gentlemen, if your fetal MCA Doppler is above 60, it is usually quite significant to suggest fetal anemia. And this is usually done by a trained expert, a fetal maternal specialist. It can be done for those who have got high titers. The recommendations is to check this weekly to screen for fetal anemia. Now, what if the baby has got a fetal anemia? The recommendation, if it's beyond term, is to treat the baby prior to delivery and to do an intrauterine fetal transfusion, which is usually also done by a fetal maternal specialist to treat the anemia prior to birth. Hence, you can prevent a stillbirth. Now, what are the recommendations if based on the MCA Doppler? If the MCA Doppler is high, as evidence of fetal anemia, then the recommendation is to do a chordosynthesis and fetal blood transfusion. If it's low, you can continue to monitor the baby based on the titer and try to take the pregnancy to term. But if it's in between, I think the trend is more important. Either to deliver the baby when you think you can actually cope with regards to the prematurity. It can be 32, 33, or 34, depending on where you work. Or if it's normal, if the trends are stable, you can actually try to deliver the mother nearer to term at 37, 38, or 39 weeks. So to summarize my entire talk, ladies and gentlemen, I think it is important to think of rhesus negative, risk profile patients, think of the father, think of the baby, but universally screen everyone. Think of desensitizing events. Antibody screening for everyone at booking at 28 weeks is important. The old guideline says less than 10 weeks, less than 12 weeks, you don't really have to give locum. That is no longer true. High-risk patients with pain and bleeding, less than 12 weeks, even for ectopic pregnancies, the recommendation is to give. After 12 weeks, the dose is 250 international units. After 20 weeks, do a Clay-Hoyer's test, but give 500 international units. I think we should manage the dosage of NTD based on the Clay-Hoyer's test, which is easily available in all hospitals. If you're uncomfortable in determining the levels, always discuss with an expert, discuss with a transfusion specialist. Moving forward, we now use a single regime of 1,500 international units at 28 to 34 weeks. For mothers who have got allo-immunized, check the titers. The titers are high, then you need MCA Dopplers. I think of sensitizing events, which should always often be in history, but check the Clay-Hoyer's test. I think the postnatal management, once again, is based on the Clay-Hoyer's test. And if you're unsure, discuss or refer to a fetal maternal specialist units. So what is current, ladies and gentlemen? All that I spoke about is not knowing the status of the baby's blood group. What is current? Some people talk about paternal genotyping to appreciate whether the father of the baby, assuming that the husband is the father of this baby, is either homozygous or heterozygous. But moving forward, where the next speaker is going to talk about all that we need to know about modern management of NTD mothers, is a non-invasive maternal blood to check the fetal free DNAs to ascertain the baby's blood group so that we can reduce the anxiety and the antenatal over interventions for a mother who's got rhesus blood group negative. So with that, some useful guidelines, if you want to know more, the RCOG guidelines on antibodies published 2015, the NICE guidelines a long time ago, 2008, but my favorite guideline that I would recommend everyone to read, the British Society guidelines on NTD immunoglobulin for prevention of hemolytic disease, which is available free online. It's a very good guideline. And with that, thank you so much for your attention.